All right, Landon, hit the disclaimer. Do you do, so NAD injection seems to be the best, but NMR and NR seem to be okay orally as a precursor. Do you do any of those or just kind of skip to the end product?
Man, if you can go straight to the injectables, cool, because that's like, here's this. Then you got NR, which is a step up. Then you got NMN, which is another step up. And then you could take stuff like niacinamide, which is way up here. I mean, but the higher up the ladder you go, the longer it takes to actually get therapeutic levels. And you also have to assume that your body's biological environment is conducive of going from here to here to here to here to making that final end product. There's no way that I know that you can test people for efficacy or for conversion. I don't know of any testing for that. So I believe if you can go straight to the source, go for it. Because one thing that people don't realize is that you got NMN that converts to NR and that converts to NAD. Increased oxidative stress can actually inhibit. It can put a roadblock right there, preventing that conversion from here to here. So as we get older, we already know we got increased oxidative stress. We got more free radicals just nabbing up electrons from healthy tissue, from lipids, from proteins, from DNAs. And that increased production of reactive oxygen species can block that conversion to NAD. So I believe if you're getting older, we accrue oxidative stress just existing. Heck, even like I said, mitochondria, like these little bitty engines. But they like, think of little sparks that come off those engines. Those are like electrons, unpaired electrons. Those little sparks are like reactive oxygen species, and those little sparks can bind healthy tissue throughout the body. So yes, while our mitochondria are essential to keep our body running, they do produce reactive oxygen species, which are unpaired electrons. And the accumulation that occurs as we get older, it's just a biological process. I mean, long story short, the more oxidative stress you have, the more inhibition you have to conversion to NAD. So therefore, if you can get straight to the product, man, go for it.
I like the combustion engine analogy with it.
It makes sense. I just tell the patients. They kind of get it.
Yeah, it helps break it down to an actual vision that you can see. Methylene blue, I mean, that's kind of I have probably the least amount of anecdotal experience with that with, patients and stuff. It does seem pretty awesome for a nootropic. And are y'all using it? Do you see any benefits with it?
Yeah, we have some patients on it. One of the biggest benefits of methylene blue is that it acts like an acetylcholinesterase inhibitor. Acetylcholinesterase is an enzyme, and so it can deplete your acetylcholine levels. Acetylcholine is a neurotransmitter involved in maintaining cognitive function. So degenerative diseases like dementia, Alzheimer's, a lot of that is characterized by having a depletion of acetylcholine. And when you lose that neurotransmitter, your cognitive function declines. Methylene blue inhibits the enzyme that breaks down that neurotransmitter, so thus your neurotransmitter pools stay higher. And therefore, it helps prevent cognitive decline. That's one of the biggest benefits of it. It also can improve your mood because it acts kind of sort of like an MAO inhibitor. So, I mean, monoamine oxidase is an enzyme that breaks down neurotransmitters, norepinephrine, that are responsible for good mood. So not only are we maintaining healthy neurotransmitters that are responsible for cognitive function and preventing cognitive decline so that we can stay mentally sharp long as possible, because let's be real, if there's one thing I fear, actually maybe I shouldn't fear it, because if I'm cognitively declined, I guess I don't know it. It's everyone else's problem at that point. I don't want to lose that. That's how I look at it. I'm like, I just shit myself. I don't know. You got to clean it. Yeah. Anyway. That's just kind of my thought. It keeps you sharper, man, and it can help with mood. So one of the contraindications, though, it does act like a monoamine oxidase inhibitor. So be careful, be iffy if you got somebody on a psychotropic medication, you got them on SSRIs, because that can lead to serotonin syndrome. I've never seen it because I use small doses. I've heard people using doses 40, 50 milligrams. I stay more in the 5, 10, 15 milligram range because I've just seen it. I'm just one of those people who thinks if you can get away with less is more.
Yeah, and it's nice that, people know that it works because it turns their urine green. So, they see that take something and, you typically feel better on it. But just if there's another objective sign that it's working, it kind of helps patients as well. And then the last kind of in the longevity space I want to talk about or just even bring up is rapamycin, just because it's, I don't know, like Peter Attia and, all those guys are throwing it around. And it's one of those, in this longevity space, it's hard to see actual protocols because everybody's just kind of guessing. And then we don't have good human studies to show, but it does seem to be the highest potential of anything right now. Do y'all use it? Do y'all have anybody that does kind of longevity stuff in y'all's clinic or anything like that?
Yeah, we use it in some patients. It's more of one of those really niche things because most people, let's be real, they probably come to you, they would come to us, all they care about is testosterone. They don't care if their thyroid sucks, which, I mean, we'll address it. But most people, when they come to us, they want testosterone replacement. But rapamycin was actually discovered from Easter Island. The scientists were studying there. They're trying to find out, how can people live here barefoot but not ever develop tetanus? Lo and behold, they discovered a bacteria called Streptococcus. Anyway, it lived in the environment, and it produced its own antifungals, its own antibacterials, its own antiviral properties. So they took this bacteria back. Well, they never found out, why they don't get tetanus, but they did discover this bacteria. And the chemical compound it makes, they actually named it rapamycin, which comes from the word rapanu, which, if I'm not mistaken, translates to Easter Island. It pays homage to Easter Island is what it does. It's a potent anti-inflammatory. Essentially, if you have any cells that are aging, which we like to call it geroconversion, when a healthy cell slowly declines and becomes a non-functional cell, it kind of inhibits that. It kind of puts up a roadblock in that conversion space. So you got healthy cells that function, they slowly decline, they undergo a process called geroconversion, then they become poor performing. Rapamycin essentially wipes the slate clean of that process. So when people implement it, what they typically do is they'll once a week, a couple milligrams once a week. I've seen some literature that shows that one little cycle of it, whether you do a couple weeks of it, can still wipe the slate clean of those geroconverting cells, those senescent cells. It can wipe the slate clean for upwards of several months. So I've seen protocols where you can just do it a couple times a year, we'll just do 2 weeks on every 4 months, and it can still have some efficacy. Another thing about it, it's a great anti-inflammatory, and it actually acts kind of sort of like a little thrombolytic. So there's some studies that show that merely being on it can actually prevent or even slow down the progression of atherosclerosis due to the fact that it has very good thrombolytic properties. So yes, it can help in terms of wiping the slate clean of these old converting cells, these slowly senescent cells, but it also can have other properties that can help, quote unquote, longevity, particularly in the cardiovascular space.
Yeah, it's traditionally used as, in transplants as an immunosuppressant, and they monitor sirolimus levels or anything. It's such a small dose that you're not monitoring sirolimus levels or anything along those lines, right?
No, I've seen most of the studies I've seen, most of the protocols I've seen are 2, 3, 4 milligrams. You take that once or twice a week. I've seen it 2 days on, 5 days off. And as you said, it's such a small niche area. There's not a well-defined protocol per se. So again, I'm more of the less is more. If you can take it, every Monday, once a week for 3-4 weeks and just kind of pump the brakes for a few months. If you can get away with a little bit, by all means. That's just kind of my philosophy towards it.
And the worst, side effects, just kind of mouth sores, and it is immunosuppressant, but it's not, when these kind of essentially, microdoses, is not too worrisome from getting infections and that kind of stuff, right?
No, I'm not worried about people getting sick or having ill effects because we're using this in otherwise healthy people. We're not using people who already have a compromised immune system. We're not using people that have a transplant. We're using people who are otherwise healthy who are just saying, hey, I just want to prevent having any kind of age-related decline. I want to keep my cells as healthy as possible. I want to get rid of all the gunk, essentially. So it's not something I would even worry about. Heck, even you're taking 2 doses a week, it's such a small dose in healthy people.
Yeah. So I do want to switch to kind of hormones now. Lifestyle optimization, hormone optimization, and these are kind of little
right on
adjuncts that we get at times, and I've done a couple videos on them, but anytime it's from somebody else from me, I think it helps stick, just hearing things multiple ways for patients.
Yeah, people like hearing opinions, seeing different perspectives on stuff.
So I do want to switch to thyroid. Thyroid is another one that, they typically are coming for testosterone. And I'll talk about thyroid, and it's kind of easily brushed off. It's, it's not near as sexy as talking about testosterone. But it is a pretty heavy hitter in terms of just energy, mood, just overall health. I would rather use thyroid optimization to lower cholesterol than cholesterol meds. When are you all bringing it into hormone optimization for your clientele and everything?
Pretty much anybody who's a new patient. Let's pretend let's do a scenario. You're a new patient, you present to us.
Okay.
We're going to evaluate your thyroid in conjunction with your testosterone levels. Because, I don't want to mask and treat one thing that could have easily been the opposing thing. If your thyroid's underfunctioning and that comes concurrently with low testosterone, there's a good chance that treating the thyroid would increase the testosterone production, because a lot of times FSH LH underproduction can sometimes be piggybacked to underproduction of the thyroid. You wouldn't otherwise know that if you don't concurrently evaluate the patient for both, hypothyroidism as well as hypogonadism. Any brand new patient, we will pull a thyroid panel and evaluate that to make sure they're not having any concurrent thyroid problems or something secondary due to an underactive thyroid.
In returns to thyroid evaluation and monitoring, I mean, you have one, the traditional primary care route just bases everything off of the TSH, and then kind of the functional guys will throw in all kinds of stuff. I mean, from what I see and monitor, free T3 can help guide me a lot in terms of symptom resolution, but are you pulling total T3, total T4, reverse T3, any of these other tests to help monitor and guide your treatment with thyroid as well?
Big ones I pulled are the antibodies. I want to know if you have Hashimoto's or not, because that right there opens up a whole another can. Because not only are you dealing with a thyroid disease, you're also dealing with an autoimmune disease. I mean, you kind of have to appropriately treat that with a more targeted approach. TSH, obviously. So, as you mentioned, traditionally, how we were trained, you and I were trained, or just medical practitioners in general, was just pull a TSH and then treat according based on that. I'm evaluating for someone with low T, I just pull an LH. And then I prescribe testosterone based on just the LH, not the testosterone, which doesn't make sense. It's a tropic, but that's kind of how we were trying to treat the tropic, not the actual hormone itself. So, but I do pull a TSH, at least initially, TPO, antibodies, free T3, free T4. I don't really pull all the other stuff because I feel like I can get my bread and butter and getting the meat of things just using the essentials. And I treat based on those right there.
Yeah, and that's kind of where we've been going is just, free T3 and symptoms. I mean, truly, we're largely symptom driven, titrate to symptom resolution. But I think free T3 has been the biggest, in guiding that. So that's kind of what we go alongside it. Once you're treating it, again, kind of the traditional route is just to do levothyroxine, T4. But we switch a lot of people off of that to desiccated thyroid, T3, T4, that's micro amounts of T1 and T2 as well. But is that what y'all are doing, or how do you all treat it once y'all are managing it? We've
treated pretty much any combination you can think of. We've done T3, T4, we've done T3 by itself, we've done NDTs, whether it's Anthiza or NP or Armor. We've done those by itself. We've done those with T3, we've done those with T4, we've done this if whatever customization is needed to get the job done, you can pretty much think that we've done it.